Sayın Kongre Başkanı ile Sekreteri, değerli meslektaşlarım, davetiniz için çok teşekkür ederim. Her zamanki gibi kongrenize katılmak ve Türkiye'ye gelmek çok hoşuma gidiyor. Başlangıçta Cumhuriyet'in 100. yılı için sizi tebrik etmek istiyorum. İstikbalı hayırlı olsun. Türkçe yeterince bildiğim için müsaadenizle İngilizce sunmayı tercih ediyorum. My disclosures, I'm under contract with Intuitive Surgical to help colleagues to start a bariatric robotic practice. I work within a group of many associates, and 2 to 4 of us do bariatric surgery. We do about 500 procedures a year, and we had an experience of 4,000. We do everything in bariatric surgery, from Laban, very few, to biliopancreatic diversion with duodenal switch. I refused to use the robotic platform for several years because at my hospital the robot was there since 2014, and I started recently, 4 years ago, with the SI, and we now have X device. I'm just like everyone. I was very reluctant to use the robotic platform because I didn't want to change. I was happy with my laparoscopic practice. I didn't see clearly the benefits of the robotic practice, and this was a game-changing approach, either for me or for the people I'm working with. So it was a new technology. We had to set up differently the operating room. I was concerned about the increased operative time. There was the learning curve, and with the SI, the stapling had to be done with the nurse assistant. But at the same time, I like challenging myself and the people I'm working with. I was looking forward to having a better view, a stable platform. I had some problem with my hand, so I wasn't unsure about the fact I would be able to continue to operate in laparoscopy. And in fact, the lack of the integrated stapling didn't prevent me to adopt this new technology with the SI platform. We have to bring the cart at the level of the left shoulder because of the architecture of the operating room. I use a bipolar on the arm 1, on the right side of the patient, and a cardiac forceps on the arm 4, on the left side, and those instruments never change. The rotation of the instruments, the exchange, takes place on arm number 3, which is slightly positioned at below level of compared to the other trocars, and I have a 12 millimeter assistant port and Nathanson lever retractor. So you know the setup of the 4th generation robotic platform. This is bu video oynayabilir misiniz? Video oynayabilir misiniz? Evet. This is a short film about the standard laparoscopic Roux-en-Y gastric bypass approach. Robotically, I do mainly Roux-en-Y gastric bypass with a few, as I will show you with a few biliopancreatic diversions and some revisions. So we start with the left cruise of the diaphragm, very limited dissection, and then on the lesser curvature, I use only the monopolar hook. The tunnel is created using the bipolar forceps, which opens the tunnel, and the electrocautery hook, which can dissect at the same time. In this view, I use the short-form stapler, but from time to time I also use the manual standard laparoscopic stapler with the assistant using it. When I'm lucky, dissection is pretty straightforward with almost only one vertical stapling creating a very small pouch. And then I move to the left side of the patient, pushing up the larger omentum and identifying the ligament of Treitz. The biliopancreatic limb is about 75 to 100 centimeters long. I don't cut the greater omentum usually. Then I use a short fabric tape to hold the jejunum in place, to do the gastrojejunal anastomosis, and this will be the area where I will divide the small bowel between the alimentary and the biliopancreatic limb. I do all the anastomosis and sewn. That's one of the benefits of using the robotic platform, and it's cheaper. I use only one single posterior layer with a running barb suture. And then I open both the stomach and the small bowel with the hook and do, again, a single layer running barb suture 3/0. I restart with the thread of the posterior layer to complete the anterior aspect of the gastrojejunal anastomosis. I never calibrate the gastric pouch or the gastrojejunal anastomosis. The next step is measuring the alimentary limb, usually about 150 centimeters, and do the jejunal anastomosis side to side, and again hand sewn. With the posterior layer, again with the running suture, 3/0 barbs suture. It's about 4 centimeters long. I wait until everything is done before dividing the small bowel, so the small bowel doesn't fall and make difficulties viewing it. I use the same suture to do the posterior and the anterior aspect of the jejunal anastomosis. And then closure of the mesenteric defect with a non-absorbable suture before dividing the small bowel between the alimentary limb and the biliopancreatic limb. This is why I put the arm 3 a little below the other ones, because you need to have some space to move the stapler. And the last thing is to close the Peterson's defect. At the end of the procedure, I routinely check the anastomosis with the blue test. This is a short video. Video oynayabilir misiniz? Sorry? Video oynayabilir misiniz? Ha? Kendi yapabilir miyim? Kendi yapabilir miyim? Evet. Tamam. Tamam, özür dilerim. Teşekkürler. This is a view of a biliopancreatic diversion with the donor switch, with the dissection of the duodenum. And this is really, in those complex cases, difficult cases, in laparoscopy, where we get the full benefit of the robotic platform because of the angled instruments and the stability of the platform and the 3D view. When I do a duodenum switch, I always divide the duodenum distal from the pylorus on the right side of the common bile duct by pulling gently on the pylorus. I will advance a little bit. I create a tunnel behind the duodenum. With the help of the electrocautery hook. And the benefit of angled instruments is that they reduce the risk for an injury on the posterior wall of the duodenum. We are always in the right direction, in the right angle. And then the duodenum is suspended with a fabric tape before stapling. Which hasn't anything in particular. So it's a 4-year experience with 351 cases up to now regarding bariatric surgery only, with, you can see, a majority of primary Roux-en-Y gastric bypasses, some primary duodenal switches, as well as revisions either to Roux-en-Y gastric bypass or duodenal switch. You'll see among the following slides different numbers, because This is a review comparing robotic cases and laparoscopic cases. I do in parallel, and regarding the operative times, we had different populations. So I wanted to compare the outcomes of the primary Roux-en-Y gastric bypasses since September 2019 between robotic assistance and standard laparoscopy, with the follow-up of at least 1 month to check for the early complications. On the left, you have a little less than 300 robotic procedures using 6 trocars, only hook and bipolar, with a mix of the short-form stapler and the endo-GIA, no calibration, 3 to 4 firings for the gastric pouch, and totally hands-on anastomosis. And on the right, you have a smaller number of laparoscopic procedures with 1 trocar less, but basically this was exactly the same procedure with hands-on anastomosis, and this time only a standard laparoscopic stapler. The populations between robotic and laparoscopic approach were similar, except there were significantly more men in laparoscopy, with a little more than 21%, against 16% in the robotic group. I must say that I don't select patients for either robotic or laparoscopic approach. And again, there was a majority of primary, there was majority of Roux-en-Y gastric bypasses only. There were all primary operations, but there were some cholecystectomies or hiatal hernia repair in addition to the Roux-en-Y gastric bypass. The mean consult time for the 150 cases for which we were able to retrieve the data was 95 minutes, including the learning curve, with a minimum of 60 minutes and maximum of 173. From incision to closure, we had 44 laparoscopic procedures with a mean time of 81 minutes against nearly half an hour more for the 126 robotic procedures. What's important for me is the OR occupancy time, because this is at the end of the day what will impact the number of cases we can perform. And as you can see, the robotic use meant a longer OR occupancy time by half an hour. But during the learning curve, we saw a decrease, which is now nearly equal in OR occupancy time for the laparoscopic and the robotic approach. And the difference for the most recent cases was only at 10 minutes. Again, this is the comparison between the 50 most recent cases, but this was 1 year back, and as you can see, there is about 10-15 minutes more, and we can have consult time as low as about 40 minutes. I also checked the white loss at 1 year, and without any surprise, there was no significant difference. The white loss, the percentage of excess white loss was the same between the robotic group and the laparoscopic group. What was really important was to see if there was any advantage of the robotic platform regarding the early complications. There is the detail of the different complications. As you can see, there is still a 12% early complication rate with the robotic approach, and a much higher complication rate, but this is not significant 17.5% with the laparoscopic approach. What's important is what is underlined in red and blue. You see that the rate of the proportion of the clavien-dindo complications with the clavien of at least 3 is nearly significantly lower after the robotic approach, 3.4%, compared to 8.2% in the laparoscopic approach. But again, these populations were not really equal because they were not matched. It was a retrospective analysis, and there were more men in the laparoscopic group. Readmissions, they are the same in both groups, and reoperations, it's not significant, but it's much lower in the robotic group, 2%, than in the laparoscopic group, 5.5%, and that's probably in relation to the stage of the clavien-dindo. When we look into the details of the clavien-dindo 30-day complications and distribution, we are within the complications as a whole, and you can see that in the robotic group, the severe complications with at least stage 3 for the clavien-dindo classification, it's about 1/3. And when we look at the laparoscopic approach, we have the same proportion of severe complications, which is up to nearly half of the total number of early complications. So it's more severe than with the robotic approach. I looked at the literature. I decided to summarize it for you because there is an extensive literature. And in the independently published literature, what we can see is that there is, for the robotic platform, an increased operative time. It can be around 15 minutes, but up to 40 minutes, according to the reports. It usually decreases after 10 to 30 cases. And except one bold database report with the match control groups of little more than 2,000 patients in each group, who found that there was a higher rate of early complications after robotic approach compared to standard laparoscopy. The literature as a whole reports no significant difference between robotic and standard laparoscopic bariatric surgery. Even in our group of the French Society for Bariatric Surgery, which published recently in Annals of Surgery, it did reduce the length of stay for people who did not do fast recovery before the adoption of the robotic platform, but it did not significantly reduce the rate of postoperative complications. So in conclusion, surely robotic surgery does bring enhanced laparoscopy to bariatric surgery. The surgical technique may need to be adapted. The robotic surgery is really good for unsoon anastomosis, although any type of anastomotic technique can be used. Similar operative times can be achieved beyond the learning curve between 30 and 50 cases. There is absolutely no randomized controlled trial or good study, but there is a possible trend for a reduced 3-day complication rate. And the literature, of course, is of very limited quality. There are no prospective studies. Thank you for your attention. İlginiz çok teşekkür ederim.